Hi, I'm Nick Galifianakis. I'm one of the neurologists in the Movement Disorders Division at UCSF. And today we are going to be discussing 4 modules on movement disorders, what movement disorders are, and then focusing really on the 2 most common presentations of movement disorders, which is tremor and Parkinson's disease. So an overview of this talk, it's going to be broken into 4 sections. First, I'm going to be speaking about movement disorders in general, speaking about some definitions and the phenomenology of movement disorders. Phenomenology is simply what the movements look like, and that's the main way we classify movement disorders. In the second module, we're going to be talking about the differential diagnosis of those 2 most common movement disorders we see in clinic, tremor and the syndrome of Parkinsonism, and going a little bit more in depth about what Parkinson's disease is, idiopathic Parkinson's disease. In the third and fourth modules, we'll be focusing on Parkinson's disease, both its symptoms and its treatment. So the first question I get in clinic often from students is, what are movement disorders? After all, problems like stroke or MS or seizures will cause problems in movement. But here we're speaking of problems with movement or neurologic syndromes, which are either too much movement or an excess of movement, which we term hyperkinetic, or a lack of movement, especially voluntary or automatic movements, which we term hypokinetic. And these are problems with movement that are unrelated to weakness or spasticity that you would see in stroke or MS, or obviously convulsions that happen with seizures. So there have been other terms to describe this class of neurologic problems in the past. A common thing people will hear is extrapyramidal disorders, but we don't prefer this anymore because knowing more about the physiology, we've come to know that movement disorders do involve the pyramidal system as well. And also basal ganglia disorders, which is where we localize a lot of these problems to. However, not all movement disorders are problems with the basal ganglia. So we really just prefer this movement disorders term, which really gets down to an excess or lack of movement. So as I mentioned before, phenomenology, or the way the movements look, is much more important to how we classify movement disorders as opposed to localization, which a lot of the rest of neurology focuses on. I'm sure in your clerkships or on the wards, attendings or residents have asked you, where would you localize this lesion? We are not as focused on that. Number one, because the movement disorders are again more diffusely localized to network issues with the basal ganglia as a whole. And number 2, really the way we start our diagnosis is by figuring out what movement we're seeing first. So again, we divide the main branches into hyper or hypokinetic disorders, being too much or too little movement. So first we're going to talk about hyperkinetic. The 4 main movements we see in clinic are dystonia, dyskinesia, which includes chorea, athetosis, embolism as well, myoclonus or jerks, and then tremor, or what some patients would call shaking. There are some others here as well, but they're outside the scope of this talk. In terms of hypokinetic disorders or too little movement, this can be broken down into slowness, which is bradykinesia, or lack of movement, which is akinesia, rigidity of the muscles, which is a passive tension felt in the muscles when an examiner is stretching in a joint, gait dysfunction, which is loss of postural reflexes or freezing of gait, which is defined as an inefficient generation of steps. And again, collectively, these are usually present together as the syndrome of Parkinsonism. Again, there are many other hypokinetic disorders which are outside of the scope of this talk. And for most of the rest of this talk, we are going to be focusing on the 2 most common conditions seen in a clinic, which is tremor and Parkinson's. So before we get on to tremor and Parkinsonism, we're going to just do a brief discussion of hyperkinetic movements. The differential for many of these is very large and, again, outside the scope of this talk. But so we're going to focus mostly on what the movements look like and what features you would be looking at to try to figure out is this dystonia or something else. So we're going to look at the features of the characteristics or the qualitative look of the movement, the speed and the regularity of the movement, and some of the variants that you can see. It's probably the best way how to approach these movements. So first, for dystonia, really what I think of dystonia is when the movement seems to be a twisting or torsion of a body part. Basically, the muscles are overactive in pulling whatever body part is involved into a certain posture. These are tending to be, compared to the ones we're going to speak about in a moment, slower, more sustained, and probably the most important thing here is that they're more patterned or stereotyped. So if a person's neck has a dystonia where it wants to pull to the right, it'll be that same movement over and over. Along those lines, if it's pulled and held in a certain posture, we call that a tonic posture. If it's a more dynamic thing where it pulls into that direction, we call that more phasic. Another characteristic feature of dystonia is that they are frequently task-specific. So some examples of this would be a musician's dystonia, or including piano players or violinists who practice hours and hours a day for many, many years of their life. There's something about the neuroplasticity of the brain combined with some probable genetic susceptibility in dystonic patients that put them at risk for developing dystonic postures in tasks that they do repetitively. Another common example is what we call dystonic writer's cramp, which would be when somebody's writing, their wrist can kind of twist into a posture, their fingers can become dystonic. Moving on to chorea. Chorea is usually characterized as a dance-like movement. Actually, in Greek, chorea means dance. These are more flowing, random movements. Their onset is more abrupt. They're quicker movements than dystonia, and they're not as sustained. They're very brief. Another thing that's very key in distinguishing some of choreic movements from dystonic movements is that they're not patterned. They're more irregular and random, and frequently that flowing aspect, one of the reasons they become more dance-like is the movements become flowing from one part of the body to another. Chorea is one type of movement we see that's on a continuum of dyskinesia. Dyskinesia just means abnormal movement, and we usually, it's by convention, mean abnormal hyperkinetic movements. Something that's a little slower and becomes more writhing than chorea is we call athetosis, and something that becomes larger and more forceful we term ballism. Myoclonus, we in lay terms are called jerks. They are even quicker than choreiform movements. They're actually lightning quick, and they're very brief. And there's a huge differential of myoclonus. And so depending on what part of the body is involved, if it's a cortical myoclonus or a subcortical or spinal myoclonus, they'll have very different looks, but they are all characterized by lightning quick, very brief jerks. Tremor is, again, what we're going to focus on a lot in this talk. The more colloquial term might be shaking. It's defined as an oscillating, regular, rhythmic movement. So these are it should be like a sine curve almost, where it's very regular and shaking, not like little irregular jerks that might be a myoclonic movement. Tremors are classified by rest or action tremors, which we'll talk about a little later. There are other forms of tremors which get confusing. There's cerebellar tremors, dystonic tremors, myoclonus tremors, where there's some overlap in all of these things, but that's, again, outside the scope of this talk. So here we're going to look at a couple examples of dystonia. This 8 or 9-year-old girl has DYT1, a genetic form of dystonia. You can kind of see that the muscles are pulling her into twisting postures, and it got worse when she stood up. This person has these repetitive, patterned dystonic movements of the trunk and the arm. When he activates the arm, there's also some dystonic posturing in his face. Probably the most common dystonia we see in our clinic is cervical or neck dystonia. You can see this lady who is, her dystonia wants to pull her head to the left, and when she tries to fight it by looking to the right, this phasic movement comes out trying to pull the head back to the left. This lady has a form of dystonia called MPH syndrome, or craniofacial cervical dystonia, where the face and neck are involved. You can see these patterned, repetitive jaw opening dystonia. She also has a little blepharospasm or closure of the eyes, and her neck is involved as well. It's being pulled backwards. And finally, this woman has a tardive form of dystonia with a lot of retrocollis. The head is being pulled back. In this video, we see a choreiform movement. This is actually a Parkinson's disease patient with levodopa-induced dyskinesia, but you can kind of see the squirming, wiggly, dance-like movements. As opposed to dystonia, which is patterned, in this case, you almost don't see the same movement in a body part twice. It will vary, and again, it's flowing from one part of the body to the next. In this video, we see a more extreme version of chorea, if you will, called ballism. These are typically caused by lesions to the subthalamic nucleus. So this lady actually had a stroke in the left subthalamic nucleus. And you can kind of see on her right side, she has this hemiballism where these large amplitude, very coarse movements are happening in her leg. Much like chorea, they're not very patterned. Here, the arm is also moving, and you can see these high amplitude movements disrupt her walking as well. So here we have a few examples of action tremor. You can see this lady is holding her hands outstretched or brought to her chest, and in both cases, the tremor really gets going. This is another lady with essential tremor. You can see it's bilateral, symmetric, both holding her hands in posture, but also when she performs action on the finger-to-nose testing. And again, when she's trying to write, the tremor really makes that difficult. So frequently we will have people try to get dressed or write or draw these spirals that you see here to provoke a tremor. We also have them pour water between 2 cups. So this is the end of Module 1, where we spoke about movement disorders in general and what some of the more common movements look like. For the next 3 modules, we'll be focusing on tremor and Parkinsonism.